Welcome back to the deep dive. Today, we're really getting into a topic that, well, many people think they know from pop culture, but the clinical reality is profoundly complex. We're talking Tourette syndrome, or TS.
That's right.
And our sources today, they give us this amazing 360-degree view, looking at everything from genetics and brain circuits right through to, advanced surgery and even traditional treatments used globally.
Absolutely. And what we're seeing is that, okay, TS is technically defined by these motor and vocal tics starting in childhood, but the real challenge in the clinic, it's the sheer variety, the heterogeneity, how different each person is.
Right.
And crucially, these incredibly high comorbidity rates. So we're going to explore why treatment often ends up targeting conditions besides the tics themselves.
Okay, so that really sets our mission for this deep dive then. We need to unpack this nuanced reality of TS. Understand that, yeah, for most people, symptoms do get better by adulthood. But there's this minority who are still severely affected, and they face huge challenges. They need these really specific kind of multi-layered strategies to manage it effectively.
So let's maybe start with the diagnosis basics. For it to be formally Tourette syndrome, the tics need to have started before 18. That's key.
Okay.
And the person must have had tics for over a year. And importantly, it has to include at least one vocal tic and 2 or more motor tics.
And the numbers, I mean, it's more common than you might think, isn't it?
It really is. Up to 1% of school kids actually meet the criteria for full TS, and then there's a wider group, maybe 3% to 4%, who have chronic motor or vocal tic disorders.
And there's that gender difference, too?
Yes, quite pronounced. Males are affected about 3 or 4 times more often than females. We still don't fully know why.
Interesting. So what about the typical journey? How does it usually play out over time?
Well, the tics themselves, they tend to peak in severity pretty early on.
Yeah.
Often it's in the early second decade, so maybe around 10 to 14 years old.
Right, in those tough adolescent years.
Exactly. But the general path is positive. By the time they reach early adulthood, something like 3/4 of kids see a really considerable clinical improvement.
But improvement isn't always the same as being completely free of tics, is it? I saw some conflicting numbers there.
That's a really important point. Older studies maybe suggested higher rates of remission, but the newer, more rigorous research, it suggests complete Woollett-free adulthood is actually, well, pretty infrequent. We're talking maybe 10% to 20% in some studies. It's much more common to have pruritus persist, but maybe they become milder.
Okay, so beyond just counting tics, what about the person's actual experience? The burden?
This is critical. Tics cause huge functional and social problems, obviously. But when you ask patients what is most bothersome, it's often not the tic itself.
Really? What is it then?
It's the feeling right before it happens, the premonitory urge.
That feeling, like an itch or a tension, that's worse than the actual ticket.
For many, yes. It's described as this vague sense, maybe itching, tingling, sometimes even an aching feeling. And it builds and builds until they have to perform the tic to get relief.
Wow. And trying to hold that back.
Takes tremendous focus, tremendous energy, and suppressing it makes that internal pressure build up to a really distressing level. It's why you see this coping mechanism, sometimes called purging.
Purging, what does that mean in this context?
It means, the child holds the tics in all day long at school. Intense focus, trying not to tic in public.
Right.
But the second they feel safe maybe getting into the car after school, the dam breaks. And there's this intense flood of motors and vocal tics. People call it the parking lot tic phenomenon.
Oh, wow.
It's utterly exhausting for the child and for the family, too.
Yeah, that paints a very clear picture of the struggle. Okay, so let's try and unpack this. What's happening inside the brain? The sources strongly suggest TS is a brain circuits disorder.
That's the main thinking now, yes. The leading hypothesis points towards overactivity in these deep brain circuits. The basal ganglia, thalamocortical circuits, BGTCC loops for short.
Okay, the BGTCC loops.
And functional studies, looking at brain activity, they suggest the metics themselves are mostly generated by changes in areas like the prefrontal cortex, the thalamus, and a structure called the putamen.
And circuits mean neurochemistry. Right, we know certain drugs work, so dopamine seems key.
Dopamine is definitely front and center. The effectiveness of dopamine antagonists is strong evidence. But the latest research, it's showing it's not just dopamine. It's much more complex. Think of it like a whole orchestra, slightly out of tune, not just one instrument. We're seeing involvement from the serotonergic system, noradrenergic, glutamatergic, GABAergic, even histamine, and the body's own cannabinoid pathways seem to play a role.
Wow, that's a lot of systems involved, so future treatments might need a broader approach.
Exactly. It suggests we need to think beyond just targeting dopamine to get more effective therapies, especially for those who don't respond well now.
So it's less a simple deficit, more like a complex communication breakdown. What about where it starts? The etiology. Genetics must play a big part.
Oh, absolutely. TS is highly heritable. Researchers found links to specific spots on our chromosomes regions like 7q, 8q, and 18q are often mentioned. And then there's the immunological angle, too. Some evidence connects past strep infections, indicated by things like ASO titers, to the onset or worsening of TS in some cases, though proving that direct link definitively is still tricky. PANDAS is the term often used there.
Right, pandas. Okay, now this next point really seems to reframe everything, at least for me from reading the sources. The comorbidities. Psychiatric conditions alongside TS are present in, what was the number? Up to 85.7%.
Yes, it's a huge majority, staggeringly high.
So if almost everyone with TS is also dealing with something else significant, should we even primarily frame it as just a laetic disorder?
That's the million-dollar question in the clinic today. Because these other conditions, the comorbidities, they typically cause much more distress and functional impairment than the tics themselves.
So what are the main ones we see?
The core comorbidities are definitely ADHD. Attention deficit hyperactivity disorder reported in up to maybe 64% of clinical samples, and obsessive compulsive disorder, OCD.
So often the biggest daily struggle isn't the disic itself, but managing attention or dealing with obsessive thoughts and compulsions.
Precisely. And the genetics actually back this up. The risk for things like mood disorders, anxiety, disruptive behaviors. It often seems more closely linked genetically to the ADHD or OCD vulnerability than directly to the TS genes themselves.
That's fascinating.
Yeah, like having OCD on its own is linked to a twofold or greater risk of mood disorders, anxiety, substance use issues. So these conditions are really intertwined.
It really changes how you have to think about treatment then. You have to look at the whole picture. And you mentioned OCD. Does atic-related OCD look different from OCD without tics?
It often does, yes.
Yeah.
Tic-related OCD tends to start earlier. It's more common in males, and the types of obsessions and compulsions can differ. You see more obsessions related to aggression or symmetry, exactness. And the compulsions often involve things like counting, ordering, touching, maybe the less of the contamination fears and cleaning compulsions that are more typical in non-choletic related OCD.
Okay, so let's pivot to treatment then. If the comorbidities are often the bigger problem, how do clinicians decide where to start?
Well, first off, treatment isn't always necessary, especially if the tics are mild and not causing distress.
Right.
But when treatment is needed, the priority should always be the most troublesome symptom. And like we've said, that's often the ADHD or maybe anxiety or OCD. And it's crucial to counsel patients and families that completely stopping all tics is, frankly, pretty unlikely. Management is the goal.
Okay, so manage expectations. Now, if you do decide to target the tics directly, behavioral therapy seems like the first stop, especially because it's safe. What is habit reversal training, HRT?
HRT is usually part of a broader package called CBIT, Cognitive Behavioral Interventions for tics. And yes, it's considered a well-established first-line treatment. It basically involves two key steps. First, awareness training, helping the person become really tuned in to that premonitory urge we talked about, recognizing it before the tic happens. And second, practicing a competing response. That's a voluntary movement or action that's physically incompatible with the tic. You train yourself to do that competing response as soon as you feel the urge.
That sounds like it requires a lot of practice and awareness. How effective is it?
It shows good results. Studies find HRT significantly reduces motor tics and overall epileptic scores. But there's a consistent limitation.
Which is?
While it's great for motor tics, studies repeatedly show it doesn't significantly reduce vocal tic scores.
Ah, so it works for movements but not sounds. That's a big gap.
It is. And implementing it can also be tough for very young kids, say under 9, or for kids with severe ADHD that isn't being treated because it really demands focus and engagement.
Right, that makes sense. So if behavioral therapy isn't enough or isn't suitable, then we look at medication. The traditional options are things like antipsychotics.
Yes. Drugs like risperidone or haloperidol, which are dopamine D2 antagonists, they can be very effective, reducing theta tics by maybe 50% to 80%.
That's a big reduction.
It is, but they come with a significant downside, the risk of side effects. We're talking potential movement problems, hormonal changes, weight gain, metabolic issues. It's a trade-off.
So not a first choice for everyone. Are there other medication options.
Yes. For a potentially safer initial approach, doctors often use alpha-2 agonists like clonidine or guanfacine. And interestingly, some trials found clonidine might actually be as effective as risperidone for some people with fewer side effects.
And what about targeting just one specific tic that's really bothersome?
For that, we have focal treatments. Botulinum toxin injections, Botox, can be quite effective for persistent motor tics that are well localized, like a specific shoulder shrug or facial grimace.
Can that work for vocal tics too, since HRT struggles there?
Sometimes, yes. It's more complex to target, but some reports show really high success rates with Botox for specific vocal tics. One study mentioned 93% improvement in selected patients. So that's definitely an option for those hard-to-treat vocal tics.
Okay. Now, what about the most difficult cases? People who don't respond to behavioral therapy or medications and are severely disabled by their tics. I saw deep brain stimulation, DBS, mentioned.
Yes, DBS is an option, but it's still considered experimental for Tourette's. It's reserved for the most severe treatment-refractory adult cases.
And it involves brain surgery.
Yeah, it does. It involves implanting electrodes to deliver high-frequency electrical stimulation to specific deep brain areas, often parts of those BGTCC loops we discussed earlier, like the thalamus, specifically the CMPF complex, or parts of the globus pallidus, the GPI.
That sounds incredibly complex.
It is. And because of the complexity and the potential risks, it requires a really thorough evaluation by a multidisciplinary team. You need neurologists, psychiatrists, neurosurgeons, neuropsychologists, all involved in the decision.
Is there one best spot to stimulate?
The jury's still out on the single optimal target. There's some evidence suggesting that stimulating the anteromedial globus pallidus might be better than sham stimulation at reducing syndromic severity, but it's often tailored to the individual patient's specific symptoms and brain anatomy.
Okay, so that's a very high-tech, resource-intensive approach. How is TS managed in places where that kind of specialized care isn't as available? Let's look globally.
That's a great point. If you look at somewhere like China, for example, access to things like specialized CBIT therapists is quite limited.
So what do they use?
Traditional Chinese medicine, TCM, is widely used and integrated into care. There have actually been clinical trials on proprietary polyherbal formulas, things like Ningdong granule and 5-ling granule.
And did they work?
The trials suggested their efficacy was comparable to conventional drugs like tiopride, which is used for tics there. But crucially, these TCM formulas appear to have much better safety profiles, fewer side effects.
Interesting. What about the psychosocial side of things globally?
Well, also in China, the guidelines actually recommend something that might contrast with some cultural norms. They advise parents not to be overprotective.
Really?
Yes, they encourage parents to reassure their children and help them interact confidently with their peers despite the tics. There's also a strong emphasis on educational support in schools, making sure kids aren't punished for tics, and working to reduce stigma.
That focus on confidence and reducing stigma seems universally important. Okay, so wrapping this all up, what have we learned from this deep dive? It seems TS is much more than just tics. It's a complex neurodevelopmental spectrum.
Absolutely. The tics are the defining feature. But the real complexity, the real burden for many, comes from those highly intertwined psychiatric conditions, ADHD, OCD, anxiety. These often dictate the functional impairment and therefore should guide the treatment approach.
Right. It's about treating the whole person, not just suppressing the tics.
Exactly. The field is really shifting towards that, looking at the whole functional context. Successful management means carefully balancing the risks and benefits. The side effects of powerful drugs versus the time and effort needed for behavioral therapy, or even considering advanced surgery in those really tough cases.
So here's a final thought to leave you with. We've seen that specialized behavioral therapy like HRT works pretty well for motor tics, but it consistently falls short for vocal tics. Botox can help some, but it's targeted. So where should the research focus next to find a similarly effective breakthrough for those really challenging vocal tics? Is it better pharmacology, refining behavioral techniques, or something else entirely?